I would like to show you today's lecture about orofacial pain, common diagnosis and management. At first, let's give definition. What does it mean, pain? According to Cambridge Dictionary, pain, it is a feeling of physical suffering caused by injury or illness. And other sources give us another definition of pain. According to Endodontics 4th edition, orofacial pain, or OFP abbreviation, is defined as pain whose origin is below the orbitomedial line, above the neck and anterior to the ears, including pain within the mouth. They are shown about localization. American Academy of Orofacial Pain gives us definition of orofacial pain, that it is the specialty of dentistry that encompasses the diagnosis, management and treatment of pain disorders of the jaw, mouth, face and associated regions. The specialty of orofacial pain is dedicated to the evidence-based understanding of the underlying pathophysiology, etiology, prevention and treatment of these disorders, and improving access to interdisciplinary patient care. These disorders, as they relate to orofacial pain, include but are not limited of temporomandibular muscle and joint (TMJ) disorders, jaw movement disorders, neuropathy. But according International Headache Society, orofacial pain defines like pain below the orbitomedial line anterior to the pinnae and above the neck. Another international organization, International Association for the Study of Pain, gives us definition that pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And word pain is from Latin word poena, means punishment. And now let's talk about terminologies. To describe pain, we use different terms. First one, algogenic. This notion means causing pain. Allodynia, pain that occurs without noxious stimulation at the site of pain. Analgesia, it means absence of pain. Instead of anesthesia, It is absence of all sensation. Please, doctors, remember that analgesics and anesthetics, it is different groups of drugs. Dysesthesia, unpleasant, abnormal sensation. Hyperalgesia, increased sensitivity to stimulation evoked pain. Hyperesthesia, increased sensitivity to stimulation. Hypoesthesia, diminished sensitivity to stimulation. Inflammatory pain, it is pain that emanates from tissue that is inflamed. Neuropathic pain, pain that is generated within the nervous system due to some abnormality of neural structures. Nociception, the mechanism that provides for the reception and conversion of potentially noxious stimuli into neural impulses and the transmission of such impulses to the cranial nervous system. Noxious stimulus, a tissue damaging stimulus. Paresthesia, an abnormal sensation, whether spontaneous or evoked. Visceral pain, deep somatic pain that originates in visceral structures. Let's talk about orofacial pain classification. Orofacial pain classification. Different orofacial pain classification based on location and in mechanisms. An international classification, ICOP-1, International Classification of Pain, developed recently considering different pain experts groups and disciplines. What about characteristics of pain? According threshold and intensity, if the intensity of the stimulus is below the threshold, pain is not felt. But as the intensity increases, more and more pains is felt more and more. Next characteristic of pain, adaptation. Pain receptors show no adaptation, and so the pain continues as long as the receptors continue to be stimulated. Localization of pain. Pain is poorly localized, but superficial pain is better localized than deep pain. And visceral pain is often referred. Next characteristics of pain. Emotional accompaniment. Pain sensations are commonly accompanied by emotions. And I hope you know it yourself. Influence of the rate of damage of the intensity of pain. If the rate of tissue injury is high, the intensity of pain is also high, and vice versa. What types of pain we know? First type, based on duration. It can be acute or chronic pain, based on duration. A popular alternative definition of chronic pain involving no arbitrarily fixed duration is pain that extends beyond the extended period of healing. Type based on cause: somatic pain, neuropathic pain, and psychogenic pain. Depending on the quality, pain can be A. Sharp, prick, well localized, or dull or edging, throbbing, and poorly localized. Type of pain depending on the pattern. Pain can be intermittent or continuous, depending upon the location. Pain can be localized, diffuse, or referred. But now let's talk about types of orofacial pain. Not pain at all, but orofacial pain. Orofacial pain can be odontogenic, relative to with dental structures, muscles, bones, temporomandibular joint, called musculoskeletal pain, connected with nerves, neuropathic pain, and blood vessels, neurovascular pain. And of course, idiopathic or unknown type of orofacial pain. Orofacial pain attributed to disorders of dentoalveolar and anatomically related structures. Usually inflammatory in nature and affect dental structures, pulpal, periodontal, or gingival pains. Other non-dental structures, pain affecting mucosal, osseous, or glandular tissues. And doctors, I would like you to remember that dentists are highly skillful in identifying and treating those eliminating cause of inflammation or infection. And now I would like to tell you about the classification, more precise classification of orofacial pain. It divides into two axes, axis 1 and axis 2. Axis 1, somatic pain. Chapter A, superficial somatic pain. It can be cutaneous pain or mucogingival pain. Division B, deep somatic pain. As I told earlier, it is musculoskeletal pain, muscle pain, myofascial facial pain, myositis. temporomandibular joint pain, osseous and periostal pain, soft connective tissues pain, periodontal dental pain, or visceral pain, pulpal pain, vascular pain, neurovascular pain, visceral mucosal pain. Second big division of first axis, neuropathic pain. Division A, episodic neuropathic pain, like paroxysmal neuralgia, trigeminal neuralgia, and the glossopharyngeal neuralgia, and neurovascular pain. And group B, continuous neuropathic pain. It can be neuritis, herpes zoster, postherpetic neuralgia, differentiation pain, atypical odontalgia, and sympathically maintained pain. And access to psychological conditions. It can be mood disorders, anxiety disorders, somatoform disorders, and other conditions such as stress-related psychological response. And now let's talk more detail about every this type of orofacial. Once again, orofacial pain has two axes. Axis 1, physical pain, and axis 2, psychological conditions. So, axis 1, physical pain. First big group, somatic pain, superficial somatic pain. It can be cutaneous pain, mucogingival pain, and group B, deep somatic pain, like musculoskeletal pain, muscle pain, myofascial pain, myositis, temporomandibular joint pain, osseous and periostal pain, soft connective tissue pain, periodontal dental pain, and second group, visceral pain, like pulpal pain, vascular pain, neurovascular pain, and visceral mucosal pain. And second group of first axis, physical pain, called neuropathic pain. Episodic neuropathic pain, paroxysmal neuralgia. The most common is trigeminal neuralgia. More rare, there is glossopharyngeal neuralgia and neurovascular pain, and group B, continuous neuropathic pains. The neuritis, herpes zoster, postherpetic neuralgia, differentiation pain, atypical odontalgia, sympathically maintained pain, and axis 2, psychological conditions. First big group, it is mood disorders. What is it? It is a situation when general emotional state or mood is distorted or inconsistent with your circumstances and interferes with your ability to function. Next big group, anxiety disorders. You know that anxiety disorders are a cluster of mental disorders characterized by significant and uncontrollable feelings of anxiety and fear, such that a person's social, occupational, and personal function are significantly impaired. Anxiety may cause physical and cognitive symptoms such as restlessness, irritability, easy fatigability, difficulty concentrating, increases heart rate, chest pain, abdominal pain, and a variety of other symptoms that may vary based on the individual. Third big group, somatoform disorders. Somatoform disorders are a set of physiological conditions where a person experiences bodily symptoms that can be accounted for by a medical or neurological diagnosis. But how can we pain intensity measure? There are different ways to measure pain intensity. First one, the most easy, it is visual analog scale. With this scale, patients themselves choose grade of pain, how patient feels it herself. There are shown different types of VAC, visual analog scale. I have this one. What principles of using that scales? Of this scale, patient herself put this line according to different smiles, but in the opposite side, doctor has possibility to measure it in absolutely numbers from 0 to 100. Next way to measure pain intensity, it is McGreal Pain Questionnaire. This questionnaire includes 78 adjectives to describe the pain. But more, they're shown schematically human's body, and patient can to put marks in different areas where patient feels pain. But they develop different other numerical scales. For example, multi-axial assessment of pain, abbreviation MAP, by Turk and Rudy. It is a 61-item questionnaire. The assessment included a 61-item questionnaire, the West Haven Yale multi-dimensional pain inventory. This abbreviation WHY-MPI, which measures adjustment to pain from a cognitive behavioral perspective. But as can we see, it is so difficult ways to measure pain intensity for dentists. And what about disease history? What we need to ask our patients? At first, of course, chief complaint. It must be, firstly, localization of pain. Then, onset. When and why pain begins. And we need to ask about characteristics of pain, quality of pain, behavior and intensity of pain, concomitant symptoms, aggravating and relieving factors. Aggravating and relieving factors. What factors can stop this pain? Past consultations or treatments. It's called medical history. And of course, past medical history and review of systems. And psychologic assessment. What about physical examination? In which way we need examine our patients with orofacial pain? At first, inspection. Hand and neck, skin, swelling, regional anatomy and orofacial asymmetry. They are shown Russia boxer after meeting with Ukrainian boxer Klitschko. We need use palpation of masticatory muscles, and we need conduct tests for strength and provocation. Of course, we need measure assessment of a range of mandibular movements. We can use standard rulers or a special device, a special scale to measure a range of mandibular opening. Palpation of soft tissues and lymphatic groups of lymphatic nodules. Of course, palpation of temporomandibular joint. And palpation of muscles of the neck. Next step, cranial nerve examination. There shown Valleys points palpation. General inspection of ears, nose, oropharynx. Examination and palpation of intraoral soft tissues. Examination of teeth, periodontium, and occlusion. I would like to show you this table. They are shown differential diagnosis for different orofacial pain disorders. Intracranial pain disorders we need differentiate with neoplasm, aneurysm, abscess, hemorrhage, hematoma, and edema. Primary headache disorders must be differentiated between migraine variants, cluster headache, paroxysmal hemicrania, and cranial arteritis. Different types of neurovascular disorders. We need differentiated between keratodynia and tangent type headache. But as can you see, the biggest group is neurogenic pain disorders. We need to differentiate between paroxysmal neuralgias, trigeminal glossopharyngeal, nervus intermedius, superior laryngeal nerve. Continuous pain disorders, deafferentation, neuritis, postherpetic neuralgia, and sympathically maintained pain. In case of present intraoral pain disorders, we need to differentiate between dental pulpitis, periodontium, mucogingival tissues, tongue, and burning mouth syndrome. If patient has temporomandibular disorders, we need to differentiate between masticatory muscles, temporomandibular joint disorders, and associated structures. But associated structures can show us pain from ears, eyes, nose, paranasal sinuses, throat, lymph nodes, salivary glands, neck. Now let's talk about type and causes of non-dental chronic orofacial pain. Please notice non-dental chronic orofacial pain. There are 5 main groups of non-dental chronic orofacial pain: musculoskeletal, neuropathic, vascular, primary headache, and mixed. What about musculoskeletal? Musculoskeletal pain can be unilateral or bilateral, and continuous or episodic. And this type of pain can be symptoms of temporomandibular disorders, or persistent orofacial muscle pain. The biggest group of non-dental chronic orofacial pain is neuropathic pain. This type of pain can be unilateral continuous. In case of postherpetic neuralgia, post-traumatic trigeminal pain, anesthesia dolorosa, persistent dentoalveolar pain or atypical odontalgia, and reference pain. Neuropathic pain can be unilateral episodic, not continuous but episodic. And this kind of pain can be sign of trigeminal neuralgia classical or type 1, trigeminal neuralgia symptomatic, or trigeminal neuralgia plus concomitant pain or type 2, and glossopharyngeal neuralgia. And neuropathic pain can be bilateral continuous. As usual, it is burning mouth syndrome. Next type of pain is vascular, non-dental chronic orofacial pain. Characteristics of this pain are unilateral or bilateral and continuous. And it can be signs of post-stroke pain or giant cell arteritis. Bifoliized group of primary headache, of non-dental chronic orofacial pain, primary headache, and its characteristics. This kind of pain can be bilateral and episodic or continuous. In case of tension type headache and medication overuse headache. This kind of pain can have characteristic like unilateral episodic. As usual, it is trigeminal autonomic cephalgias and episodic migraine. And primary headache can has characteristic like unilateral continuous. It is sign of chronic migraine. And last group of non-dental chronic orofacial pain can has characteristics like unilateral or bilateral, and it is always continuous pain. It will be signs of persistent idiopathic facial pain or cancer pain. And what about pain management? How can we treat pain? At first, obviously step it is education and examination. Precise education and precise examination. Of course, must be counseling. Treatment of orofacial pain must be in collaboration with another specialists, not only dentist, but other specialists like neurologists, surgeons, ophthalmologists, and many others. Medication. For treatment of pain, we can use non-steroid anti-inflammatory drugs. In case of severe pain, we can use opioids. And sometimes we need to use adjuvants, anticonvulsants, antidepressants, and topical anesthetic, capsaicin or topical non-steroid anti-inflammatory drugs. We can use another different techniques for pain treatment, like transcutaneous electric nerve stimulation, or nerve block, or acupuncture. Of course, sometimes we need to use psychological therapy, cognitive, behavioral. And we can propose for our patients relaxation therapy, biofeedback, mental imagery, yoga, meditation. Now let's talk about group of orofacial pain like temporomandibular disorders or TMD. At first definition, what does it mean, temporomandibular disorders? It is different mechanical and painful conditions that affect temporomandibular joint, masticatory muscles, and or the surrounding structures. Temporomandibular disorders affects around 5% to 12% of the general population, but more females than males. Painful temporomandibular disorders can be divided into muscular, if the origin is the muscles of mastication, myofascial pain, articular, also called arthralgia, if the pain originated in the TMJ. In this table shown validated diagnostic criteria according to Schiffman and Herrero-Babiloni. They are shown that myalgia, it is pain of muscle origin affected by jaw movement, function or parafunction, replicated by provocation test. In history, this type of pain is positive for both pain in the jaw, temple, in the ear or in front of it, and pain modified by jaw movement, function or parafunction. How can we to examine this kind of pain, confirmation of pain location in the temporalis or masseter muscles, and report of familiar pain in these muscles after palpation or maximum unassisted opening. And validity sensitivity is 0.9 and specificity 0.99. Next big group of pain, myofascial pain with referral. What does it mean? It means that pain of muscle origin is described for myalgia with referral beyond the muscle area behind palpated. What about history? History positive for both. Pain in the jaw, temple, in the ear or in front of it. And pain modified by jaw movement function or parafunction. Like previous group for myalgia. Examination. First point, the same like in previously group, confirmation of pain location in the temporalis or masseter muscles. Then a report of familiar pain with palpation of these muscles and report of pain at a site beyond the boundary of palpated muscle. And sensitivity is 0.86 and specificity 0.98. And last big group of pain in patients with temporomandibular disorders, according to Schiffman and Herrero Babiloni, arthralgia. This pain is described like pain of joint origin affected by jaw movement, function or parafunction replicated by provocation test. History of this kind of pain. Pain in the jaw, temple or in the ear or in front of it. And pain modified by jaw movement, function or parafunction. As can you see, history is the same for all three types of pain. What about examination? Confirmation of pain. Location in TMJ area in case of arthralgia. Report of familiar pain in the temporomandibular joint area with palpation of the lateral pole of or around it, or maximum unassisted opening lateral or protrusive movement. Sensitivity is 0.89, specificity 0.98. Now let's talk about myofascial temporomandibular disorders. Myofascial group. Location. Angle of mandible, check temple intraoral. Can be unilateral or bilateral. Why this location? Because the angle of mandible, the attach musculus masseter, check or cheek muscle, temple, musculus temporalis, and intraoral. Onset. Why this myofascial pain can begin. Onset variable. It can be dentist appointment, upon awakening, or stress. Quality of this type of pain: dull, itchy, boring, burning. Intensity as usual, mild moderate. Frequency variable. It can be sporadic or continuous pain with fluctuations. Duration is different too, from minutes to continuous. Triggers or aggravating factors, as usual, it is jaw function. And elevating factors: cold, heat, analgesic, medications. And other associated symptoms for myofascial pain in patients with temporomandibular disorders. It can be malocclusion, limited mouth opening. What about articular pain or TMJ arthralgia? Location: in area of joint, preauricular area, ear, cheek. And as usual, this kind of pain is unilateral. Onset: acute after yawning, biting, trauma. And quality as usual is sharp and edgy. Intensity is from moderate to severe. But frequency is variable and related to function. Duration of this pain from seconds to continuous. Triggers factors, of course, yaw function. And elevating factors: cold, heat, analgesic medications. And other associated symptoms are the same: malocclusion, swelling, limited mouth opening. And how we need to treat temporomandibular disorders? What is management? At first, self-care. Avoid aggravating and contributory factors as gum chewing, clenching, coughing, wide jaw opening, bruxism. We need to use night guarding. You can see person with the widest mouth opening in the world. You can see they are more than 10 centimeters. Physical therapy to reduce pain, gain function, and improve posture and coordination, etc. Health psychology. Recognize dysfunctional beliefs and behaviors, stresses, reduce pain, etc. And mouth guard. It is not greatly superior to placebo, but it's helpful sometimes. And of course, we can use medication, injections. But this type of treatment is short term, not so long. You can see it is emergency treatment. And very rare, we can use surgery. So surgery interventions into temporomandibular joint. Now let's talk about neuropathic pain. As usual, the most often it is trigeminal neuralgia. So trigeminal neuropathic pain can be of three types: post-hepatic neuralgia, post-traumatic pain, or neuritis. According Zakrewska and Linsky, trigeminal neuralgia is most well-known episodic neuropathic condition, estimated to affect 11 out of 100,000 individuals. This type of neuralgia, some subdivisions include: it can be classical, when a compression of cerebrovascular superior cerebral artery that can cause demyelination of the nerve root is suspected, or secondary subdivision, secondary to other diseases such as multiple sclerosis or space-occupying lesions. I'd like to mention you about areas innervated by a trigeminal nerve. You know that trigeminal nerve has 3 branches, and in case of first branch injury, patient will feel headache. But in case of second and third branches injuries, patient will feel orofacial pain. So, trigeminal neuralgia. Its location, most common in a third or second branches, third or second branches. You know that third branch called nervus mandibularis, second branch called nervus maxillaris. And as usual, it is unilateral pain. Onset is variable, multiple. Quality of pain. As usual, it is electric, sharp, shooting, stabbing. Intensity is very high. Frequency 10-30 attacks per day. And duration from 1 second to 2 minutes. And the present refractory period. What aggravating factors? It can be multiple factors like light touch, talking, chewing, chewing, toothbrushing, cold, wind, and many others. And alleviating factors are very simple. Avoidance of triggers. and other associated symptoms with trigeminal neuralgia. It is hemifacial spasms, usually not accompanied by autonomic symptoms, can wake up from sleep. Now let's talk about classification of trigeminal neuralgia. Trigeminal neuralgia can be primary or idiopathic trigeminal neuralgia. The tic-doulorex more common and female injured more often than male. And secondary trigeminal neuralgia. It can be caused by trauma, nervous system lesions like tumor, vascular malformations, multiple sclerosis, facial pain, maybe lateral in case of multiple sclerosis.